and health is reshaping the future for millions, particularly in the global south, where vulnerable communities face disproportionate risks. Yeah. So tackling these challenges requires visionary leadership and transdisciplinary expertise. So today I have the privilege of introducing 3 experts working at the forefront of climate and health. Sorry, yeah. We have YouTube live as well, so welcome to you all online as well. And today I introduce you Professor Rainer Sauerborn. Very close. He's a senior professor of climate change and health at Heidelberg University and a leading figure in global health research, and with extensive expertise in intersection of climate change and health. He has spearheaded numerous interdisciplinary projects focusing on vulnerable populations in low resource settings, like in the global south. He was a former chair of the Heidelberg Institute of Global Health. And Dr. Sauerborn has also held prestigious positions at Harvard and the University Paris-Cité, contributing to pioneering research and educational initiatives. His current work integrates innovative methodologies such as sensor technologies and climate modeling to address pressing global health challenges. So I welcome Professor Rainer Sauerborn here. We also have invitees from other institutions around, from Pune National Institute of Virology, Pune Knowledge Cluster Center, and Symbiosis Statistical Institution, ICER Pune. Yeah. I will introduce Sandra again later. After. We also have Dr. Revati Falke, who has been a long-time collaborator with us. After each lecture, we have a Q&A session where it can be interactive and where you can have questions and answers, as well as we will take online questions from YouTube Live as well. And then after the first lecture, we will have Dr. Sandra's lecture as well. And we are keeping this climate health dialogue alive. We'll have conversations after this as well on a long-term basis. So we hope to keep this collaboration alive with all of you. Thank you. Professor Sauerborn.
No, I don't need the mic. Well, Roxy, thank you very much. It's the 3rd time that we met in person, twice here, when I was here for the first time about 10 or 15 years ago, with Professor Beek being still at the helm. And so I have very nice memories of meeting you and being here. Thank you for inviting me. And as I show you, I need some pointer. Here, yeah. This is Heidelberg. Now we have the winter. You have the winter now here, but the winter looks different in Heidelberg. There's a little bit of snow, but we are missing the snow. Christmas is supposed to have snow, white Christmas, but it gets less and less probable. So climate change and health, the gaping gap. How can we fill it? We have the climate science group, we have health people, and they usually don't talk much. We are an exception here. So the structure of my talk is like this. Just a quick overview. What are the climate change impacts on health? Then research gap 1, quantifying and attributing health damage to climate change. Then linking health impacts to climate models. That's where you come in. What can we do to project exposure response functions into the future to 2100 or even to the next season, as you said. Discussion. And then I show you, we call it population and Climate Lab, where we have long-standing collaborations with the kind of cohorts they're calling HDSS, Health and Demographic Surveillance Service. VADU is the most known here, 100 kilometers from here. And then we add certain things to make it climate ready. And then, of course, how can we collaborate? So I hope this will have, as you say, an afterlife, our discussion here. Okay, just a quick one. The relationship between health and climate is multifold. Health is a motivator. Why do we care about health? Why do we care about climate change? Not because of panda bears, not because of ice bears, but because of our children, our grandchildren, and that is what motivates policy, motivates individual behavior, and also researchers sometimes, at least myself. It generates co-benefits. There's also the green stuff is positive, and the red signs you will see are dangerous. So health, as you know, if you don't eat red meat, if you move a lot, you are not only doing something for the climate, but also for your health now and only for you, which is a very important sales argument if you like to change behavior. The health system can, to some extent, adapt or protect populations from some effects of climate change, but certainly not for all, and certainly not if we have runaway climate change. So there's some possibility, but don't look to the white coats to save you from the health effects of climate change. This is not possible in an extreme climate world. Yeah, then health is a victim. Our health is endangered or threatened or even damaged by climate change. We are perpetrators of the health sector. 6% of the Germany, the footprint, CO2 footprint in Germany comes from health. In the US, it's 12. In low middle income countries, it's of course a little bit less, but if you become more equipped with big hospitals and so forth, that will change as well. So we should also look at our own footprint. Then there's the health-mediated loss of productivity. We talked about this quickly. I will get a little bit into this. Particularly heat is dangerous here. And then there are losses, particularly to countries like India and Africa, sub-Saharan Africa, loss and damages is a big topic in the climate conferences. And so first thing, it was mitigation in Paris, then adaptation in Glasgow, in the Glasgow COP. And now the world realizes we haven't done enough on emission control. We haven't done enough on adaptation. So what's left has to be compensated, which is really a plan C. So countries are given from a big fund, are given money to defray the cost that they have incurred, and health is one of the largest costs of climate change. And research is all across, of course, and we are talking today about these three black labeled what are the health impacts, what can we do for adaptation, and the work capacity. So, I mean, sorry if I bore some of you. The greenhouse gases, of course, and the emissions and the loss of sources leads to a lot of health impacts. And in the report of the Lancet Commission, there's an amazing maze between sort of like spaghetti arrows that go from one climate dimension, climate change dimension, to the health. So if you see in red here, that's probably what we are talking about: higher temperatures, rainfall changes, and air pollutants, if I may propose. And then you have undernutrition, diarrhea, and the red again, that's the effects of the above, mainly cardiovascular, respiratory, and vector-borne. But there are more than 100 diseases that are made worse by climate change. and there is no climate change disease. So climate change piggybacks on diseases, but doesn't create a new disease, which would make life for epidemiologists, Javari, much easier if there was a disease with green dots, or then you have climate disease and you have a climate disease. Then we could say 2 out of 100 is the prevalence. No, and now of course, who gets it? It's not uniform. To whom, how much, where, and when. So this is the broad overview. And then there's another conundrum, as I just said. The red part, this is a cartoon. We have the infectious diseases here. We have injuries and drowning, and then the chronic diseases, non-communicable ones. And everyone has a certain base, which is counterfactual, not climate change influence, and then a certain delta, a certain increment, and that is climate change. And the politicians and climate meetings, the COPs, they want, what is the health damage of climate change? And in an ideal world, if we knew everything, we're working on it, but we're not yet there, we would add all these red bars to one figure, which is the burden of disease from climate change in DALYs, if you know disability adjusted life years, which is the new unit of damage. Okay, so that's the challenge, to tease out for every of these diseases, or maybe for the 10 most important one, that part which is attributable to climate change. Then one climate component, like heat, has multiple health effects, not like a one-on-one. That would be relatively easy. So heat can lead to heat stroke through cerebral thrombosis and other things, and dehydration, kidney damage, renal stones, cognitive malfunction, depression, lower work productivity. So many health effects by one signal, if you like. This makes our life a little bit more difficult, but I think one can handle this. And indirect, of course, food security via many pathways of direct impact on the plants, but also direct impact on the work productivity of farmers. These are construction workers in India, just one group. Now, how do you study, that's a general question, how do you study any impact on society of climate change, on real population? We're not in the modeling world, but we look at the reality on the ground. And this is my mentor, Tony McMichael. It's a slide, old, but still very correct. So he said, yes, climate change unfolds over decades, and your funding from the Indian society of this and that, or the German society, is 3 years, maximum 5 years. So either you lie or you don't apply, unless you follow Tony McMichael's advice. So you need to look at longitudinal data sets. Where do we get them in health? Well, you can look at hospital records and so forth, but they are notoriously invalid, and biased. So if you look at it at the population level, you will have to look at longitudinal cohorts of health data. So what he said to me and to others, of his students, learn from the past. Look at time series analysis, heat, mental health, and so forth. Detect impacts in the present and project to the future using climate modeling. And then if you are looking to the future, you can also look at interventions, adaptive strategy, and so forth, which you can't do, obviously, in retrospect. So many of these, let's say, model ups started in 1960. So you have already 65 years of very good health data. And others, I mean, the average age of these cohorts, these labs, is around 30 years, which is already sizable. And I show you, we didn't do everything and we didn't do it perfect, but this is the closest that we got to the lessons of Tony McMichael to honing his advice. So we looked at retrospectively, that's the left part here, and this one, what are in the last 25 years of such an HDSS in sub-Saharan Africa, what are the harvest out, now the harvest failures, and what is it? Was it due to? This is the harvest failure due to weather variability, and this is the total harvest. So 67% of the harvest failures are from, if you like, weather variability strictly, but not so strictly from climate change. And now, well, these are of course, we work with the Potsdam Institute for Climate Impact Research. There's a crop model, an agricultural model, and a health model, which we worked on together. And then we could project to 2100 under a 1.5. At the time, we were still optimistic, warming till the end of the century. This was the message. The all-cause mortality of children, mainly due to malnutrition, of under fives from weather-related crop failure, would increase about twofold under a warming. So that is the kind of prototype which we would strive to emulate, having empirical data from retrospective and from current, and then having prospective data with the help of you guys. I think this is known to everybody. At least we talked about, this is ILO data about the fall in your work productivity. This is somebody who cuts trees, 500 watts. This is maybe you who sit in front of a computer. But all of us have the steep decline, and the decline is amazing. It's 50% due to a warming of 2 degrees. The world produces, those who are exposed to heat, produces less, enormously less. This is the 32-degree threshold that physiologists, I know there's no standardized threshold, but 32 is certainly a threshold above which health problems arise exponentially.
This is for which have been worked out, for which population? No,
this is not the population. This is, you mean this is just a graph.
Based on?
Based on the ILO did this.
For the global.
Yeah, it's a global. It's not based on particularly empirical data that I know. So I should have told you that this is wet bulb globe temperature, meaning humanized temperature, a mixture of moisture and temperature, which has also its problems. But and then this percent work capacity. So that graph is around for decades. They must have tested it in physiological lab. I don't know.
Recent paper, 3-4 years old.
Which they have a paper 4 years old.
Yeah, a very recent paper has updated this kind of.
Yeah. Okay. Send it to me. You see, I learned already something. And then we gave it to the PIC. Fred Hattermann is one of the modelers at the Potsdam Institute, and he downscaled, which is something I want to recommend to you as well, for VADU, downscaled the regional models to the size of this lab population, which is a contiguous population. It's not a sample, but it lives in a district. And it's roughly 20 by 20, like VADU, 20 by 20 kilometers. So it is very difficult now to downscale, but it was done. And you see when this line these are the different climate models. And this is the line, 32 degrees. And you see in West Africa, this is Nuna. West Africa, the line is crossed in 2030 by almost 2040 by all models. And here in Kenya, at the Lake Victoria, much later, but it's also crossed. So just to demonstrate, to illustrate how this could be done. Of course, India is in the, I don't need to tell you, this is very exposed to heat. Middle and low income countries are estimated to lose 2 to 8% of their GDP. So this alerts now the Ministry of Economy, the Prime Minister, everybody. It goes beyond health. Well, this is a randomized controlled trial with these roofs where we have a very high-tech film of surface to paint on these corrugated iron roofs, and it cools the inside by 2 degrees, almost exactly what would be expected. And it was shown, and we used as indicators heart rate, dehydration, blood pressure, cognition, air temperature, humidity, thermal comfort. So it's tricky to really assess the impact and also the protective effect of interventions. You have to go a long way to define your outcomes, to define your exposure, and to have an intervention. So now we come to the core of my talk. I want to show how this population lab has been developed to include climate. This is what is done in Wadu, where I lived in sub-Saharan Africa for 35 years. And only 3 years ago, this other model, the climate model, was developed in Nuna. And now we are expanding it. It's already four of these HCSSs who've done this. But what is wonderful is that it's long term. As I said, MATLAB, 60 years. And that it looks at death, out-migration, birth, and in-migration, but not more. So it's a death accounting business, which is a little bit unsatisfying, particularly when it comes to climate change, where you want to have early signs of physiological failure of disease. So we thought with our colleagues from Africa and also from Malaysia, what can we do? How can we measure health and climate synchronously? And the first thing was we should not only look at the outcome death, which is too late and too coarse, and you can't do anything anymore. So there needs to be a component adding life lived with a disease before death, disease, acute, chronic handicap, and there needs to be an element of climate variables to be a little bit imprecise. And that we call that CHEERS, Climate and Health Evaluation and Response System. So I compare now HCSS, think Wadu, and CHEERS is the new system. And tomorrow we're going to Wadu because they're very interested in having this. So full population cohort, yes, both. Death cases, both. Cause of death by verbal autopsy, interviews to the next of kin of the defunct. And then comes the morbidity. You can't have the 10,000, the 100,000 people all with a morbidity questionnaire and all with sensors and so forth. It's too expensive. So we took a 10% subsample, randomized, still representative. So if you have 100,000 of this cohort, you still have 10,000 individuals on the morbidity, in the morbidity sub cohort. And then you go for acute. How we go about this, we'll let you know. But we'll acute and chronic illnesses, disabilities, wearable sensors, core temperature, pulse rate, blood. So the objective measurements of health. We eliminate seasonal bias, which is grave because health people like to not wet their feet. So they go out in the nice season, which has a completely different profile from the monsoon season and so forth. So we sample every every cluster of households in every week of divided by 52. So every week of the calendar has the same number of households interviewed and measured. And then we have, it comes green as this meteorological and environmental weather stations within the HCSS area, indoor temperature and humidity sensors, satellite data for harvest surface water. And how this is done, Sandra will tell you what sensor and how do you 3D print a weather station and so forth. And we have a particular database architecture. This morning we talked, we need interdisciplinary collaboration. It's true. But your data and our data are completely different in terms of temporal space. The malaria cycle is maybe 15 days, and your climate model is a slightly longer temporal frame. Seasonal and spatial differences, formatting differences. So if you want to have data sets streaming in from sensors, from interviewers, from weather stations and from remote sensing, you need a database that can handle this. And we searched and found that graph databases do the trick. And they are also best to apply machine learning and artificial intelligence in the end. And Sandra will tell you more about this. So that is the improvement, all of this here. The one part is measuring disease as it occurs, and one is measuring the climate relevant variables in and outdoor. Now, this is now a little bit complicated, this slide, but we have now, let's say, 6 years, or you can have also 16 years, whatever your time frame is. It should, these cohorts never end. There's only 1 out of 65 which was stopped, and 1 cohort which has had a gap, as I will show you. So it's amazing. These develop their own life and their own funding, and it's a precious global good. So here you have the green is the heat part, or the let's say the environmental part, outdoor humidity, rainfall, home environmental, that's what I just said, satellite imagery. And then here is a little bit more detail. Household survey is the perceived acute and chronic comorbidities, injuries, handicaps, demographics, and then the wearable sensors, and then also as is indicated for your research question, blood, urine, sweat samples, and so forth. Here you see, you don't have to read this, you can't read it anyways. Every bar, the green bar represents an Asian, an African, no, an Asian HDSS, and the green bar, an African one. And here you have MATLAB, the beacon, 1960, this is today. And you see, this is 60 years. The average is, as I said here, there are 60 and counting sites. The average population size 75,000. Vado has 100,000 roughly. Average age of the cohort, it may be now 27 years. And total population is 4.5 million, and the total person years observed 150 million. So you have the benefit of variability, and you have the benefit of a large number. And we try now to convince most of them or to add these components to make it into a cheers. And here is, if you have a red flag like this, they are already operating as a cheers. And they are 1, 2, 3. And these are currently preparing for cheers. This is also 1, 2, 3. And the yellow ones are planning, including MATLAB. We have a meeting with them soon and so forth. So you see, this is the base HDSS picture. And if we get many of them, particularly in India, you have 16 HDSSs in India. It's not only Vadu, at the coast, in the mountains, in the jungle, in all the hotspots of climate. So maybe that would be a task worth doing. Well, we work with the Potsdam Institute of Climate Impact Research here. And I just wanted to show you, it's nice for you to look at other Europe, Germany, Amazon, there's India, and all of them don't have health. They have agriculture, meteorology, climate, and they have all sorts of things. Can you click on this live? Yeah. No, it's not a research tool. It's more of a tool for the population. So you can. This is now India, and you can select an indicator. Here we have maximum air temperature. You can have a time window, and you can. Can you click on the? It should move. Well, it should be moving. Anyways, this is not something that surprises you, but it's something that's good for visualizing things, and you can look at other countries. But my key message is health is missing everywhere, including Germany, including Europe. If they say health, look, it's heat. And that's all. And only the temperature, WGBT, but not the impact, like renal stones. And so it's amazing. Health is the main driving force for us to deal with climate change. And health science is not prominent in working with climate science. And thank God, can I get back to the normal? Yeah. So Potsdam Institute for Climate Impact Research, that collaboration was so fruitful, and they were so grateful to work with real health people. And we were so grateful to work with modelers, but impact modelers. And this is therefore an important link. And we would look to you as our pig, if you like, or the pig of this network of cheers. So this is a project we got with pig, not pig, pig. Getting slightly, and we could now change it. We had malaria, heat, and we had undernutrition in our consortium with them. Could be pollution, heat stress, and infectious diseases. Then this is crossed with impact assessment, adaptation, interventions, and projections. That's where they came in. And here's the population cohorts that are just described. Then adaptation is something that we do, community randomized controlled trials, and then climate impact models and the adaptation, the effect of adaptation. This has rarely been modeled in climate impact. It's always called climate impact research and not adaptation evaluation. Anyways, so that was the big deal. You see, this was a project that this is a colleague from Nuna, from Kenya, and so forth. So here's the flow of data changing hands from health empiricism and modeling. So health impact studies, adaptation trials, they create exposure response function and adaptation response functions, which are then inserted or joined in health impact projections based on EasyMIP. You probably know that. It's one of these pet models which combines many impact models of the world. EasyMIP, so this is a climate impact model. Then you have a health impact projection possibility and an adaptation projection. And then this is something we also had a policy, because policymakers don't want to have data from Nuna or from Vadu. They want to have data from India or from Pune district, and how to upscale it is now something we need to discuss with you and also with statisticians. Okay. Ideas for collaboration. Focus on IITM health priorities. So far as I gleaned until yesterday, it was heat, pollution, and infectious diseases. Mostly waterborne, I take it, but there's also airborne. Anyways, focus on your the health priorities that you have chosen. Focus on Indian cheers, health and climate population cohorts. Vadu symbiosis has one in a slum, even in Pune. There are 16, as I said, 16 HCSSs run by Sanjay Juvekar. Many of you know him. And so we are also working with this network, and maybe we can discuss where, in your view, from the climate side, where the hotspots in India, where you would like to have this. In addition, I thought also about this Urban Delhi project, where you have a zillion of climate measurements and no health measurements. So let's engage in that discussion. Did I go through everything? Yes. Yeah, this is what the health partner provides. I mentioned that. And that is what we would hope you can do, namely downscale. This is Vadu. Downscale 20 kilometers, downscale climate model, the most up-to-date climate model to the side. I don't know how to do this, but I know it's complicated. But this is why you are experts here. Regional PM 2.5 can be, you know how to measure this, we know how to measure this in the huts. Humidity, precipitation patterns, remote sensing. I know that you are good at this. We have a company who does crop harvest quantification by the size of the field of a household. In Africa, the household has 5.6 fields, and they can see what's grown in every field and how much is harvested. And this is great to correlate this with heat and work productivity and all the rest of it. So, but we can see you must have enormous experience also in remote sensing. And assistance, and now you will see we will put up local meteorological stations, and we may need your advice in calibration. Join publication conferences. COP30 is around the corner. We could have a joint session on our collaboration in the Indian pavilion or a side event in the UNFCCC. So the sky is the limit. If we put our energy to it, I think we can make it till then. Otherwise, COP31 will do the trick. And that is our old university. We also have fancy new buildings, but I know you like this historic buildings. So, and this is my last slide. Our motivation is not the models, not the science, but it's the children. I have one grandson only by now, but I hope others are coming. And and this is wonderful. So Dhanyavad. Our motivation. Thank you. That was it. Because you're staying time. Yeah.
Dhanyavad, Rainer. It was a wonderful session and gave us a lot of ideas on where we can work together. Yeah. So we will take some questions. I mean, if you are online, that as well, in-person questions first. Yeah. So students and everyone, please feel free to ask questions.
Yeah, thank you for that excellent overview. I wanted to flag the role of traditional knowledge in dealing with climate, because climate extremes are part of human evolution and traditional knowledge has developed to cope with that. How do we account for the role of traditional knowledge in meeting the future challenges and combined with the lifestyle changes that are happening, which also exacerbate the climate impacts?
Well, it's obviously a very, very good, pertinent question, and it's very difficult to answer, of course. We have several papers on the perception of climate change. There was one in Bangladesh and one in Africa. And what are your coping mechanisms? Yeah. Yes, I mean, people are clever and they have all sorts of, they go earlier out in the field, they stay under a tree and so forth. There are, of course, the usual ways of avoiding heat, for example. But I think I must say that this has limits. And yes, heat waves have been with us but not the inexorable warming. And so the heat waves gets on top of a warmer climate and not the downpours. So I don't think that traditional knowledge can do the trick in adaptation, in personal adaptation, but it can certainly help. And it would be great to stick our heads together how we can ask maybe more specific. What do you do? And what can you recommend somebody else in another African country? That's a very good point. Thank you.
You already have a mic.
I have a mic.
Other questions?
Just if one fails, I have another one.
Yeah.
Hi, thank you for this wonderful presentation. And I would like to ask one question. There in India, currently people are started studying the impact of the climate extremes over the socio-economic and the health impacts. And this have been done over the historical period and observed period. I would like to, what are the framework we should adopt to study the impact of the climate extremes under the future upcoming? What you have been just shown, it's hard to grasp in half an hour only, but I would like to know what could be the framework and what are the is there any model exist that we can visualize the impact of the climate extremes over the let's say event specific health assessment. So is there any framework?
Well, thanks for the question. Of course, think about, by the way, my presentation and Sandra's is left on for you to walk through in peace and quiet. I know it was a lot of information. So you can look retrospectively. You remember the graph? 20, 30 years and look at mortality only, unfortunately, but you have the long time frame, and it's always easy to get meteorological data, coarse meteorological data from the national WMO weather station and so forth, and look at when was this peak in temperature and what was mortality doing afterwards. And then you have a lag, then there's a DLNM, distributed lag non-linear modeling. It's a kind of time series analysis where you can see, okay, I have this signal, I have this peak in death. As death, we discussed this in the morning, as the cause of death was not, or is just now being attuned to climate change. And it's not obvious if I have a renal stone and I die from it, God forbid, whether was it the climate or my diet and so forth. But we have to do the verbal autopsy to encapsulate also climate as a risk factor. There are several risk factors that lead to the final death. And so you can do this with these HDSSs, mortality, and you get the signal from temperature from the local weather. That's easy. Now, in the future, you need, I think you need cohorts where you can now shape your own data armamentarium. And there's even, it's not even better, because now we have in this 20 by 20 kilometers, we have 5 weather stations who send direct data, and you can even see the pulse which reacts to the sweat quality or the sleep quality. All this is captured by sensors. So there are many ways. The problem is that heat waves are rare. If you look just at warm temperatures, you have many more pairs of exposure response, but they become more and more frequent. So you can look at heat and you can look at heat waves. But the principle is always the same. Get the signal, look at death retrospectively on disease and physiological reactivity in the future. Was a long answer to a very good question.
Thank you.
I just want to know, is there any other sites and what are the institution we should target to get these kind of data? What are the, is there any particular framework that we should rely on these kind of data? Or is there any global data set is available which talks about it?
Don't look at global data sets. Don't look at hospital data. They are picturing a biased picture of the population. I would really go for this. You have 16 HDSSs in India. You have Vadu next door. I think maybe IITM should look into being a stakeholder in the Vadu, like your field station. Well, that's an old-fashioned word. Your population and climate lab. Maybe it's also good for you to invest literally, not only intellectually, but also literally into that exercise and say, let's work together to set this all up. And then it's our joint measurement. Of course, this is linked to KEM. Yeah. They want to provide services, which is all nice, but you want to do research and maybe intervention trials. So, but as I said, if you want to look at others, there's the Indian HDSS network, IHN. It has a website, and there are 16 and counting. And by your luck, and maybe with the help of the institute, where are if you want to have more, one lab in the coast, one lab in the jungle, one lab, I don't know, in the urban, then it's for you to contact them and say, hey, can we work together? Mm-hmm.
More questions? Sushmita? Dr. Sushmita works with the extended range prediction for heat waves and other kind of extreme weather events. So, I mean, she has been working on the health front as well, right? Yeah.
Raju's PhD work, so he can.
You're dedicating this to you.
No. Anyway, just part of the discussion. Yeah. Do you have some comments? No. We were just introducing your work. Yeah. Any more questions? Okay. I know it's a bit early for this conversation. But one of the things that from the climate front that we are working on is compound weather events. And now and when it comes to the health impacts, it may be much more intricate, but I want to know if the community has started thinking about it. For example, the 2022 heat wave season in India, that coincided with rainfall deficits, which percolated into the agriculture sector. There was 20% reduction in grain production and so on. At the same time, there were wildfires, air pollution, and heat waves all together. Yeah, the impact was huge, and this was before the monsoon during that hot season. So the impacts on health, I mean, we cannot even imagine, but I think maybe on the long run, this is something we want to work together on. But
yeah, it makes things much more complicated.
Yeah.
And I think one should walk before one tries to dance.
Yeah, exactly.
And Roxy, you're the first to join me on this. If you do heat and depression or heat and work productively, that's already a simplification of reality, of course, But let's start with this simple model and then add. And as I showed, even the health effects of heat are multiple, and the drivers, your climate drivers, are multiple. How to add them is really a task worth the sweat of the best minds on both sides, maybe. That's something exciting we could do together in the future. But for the moment, I suggest to start simple. Yeah. Make sure we work seamlessly together, and then we add a little bit here, we add a little bit there, and we get more and more complicated and complex.
Yeah.
But the question is absolutely right. The question is right.
Thank you, Professor Rainier Sauerborn, for a wonderful talk and discussion as well, and inspiring us with several ideas to work on. Thank you very much.
It was my pleasure. Thank you.
So I would like to, before we move on to the next talk, I would like to talk about the organizers from IITM, the desk department, development of skilled manpower in Earth System Sciences, organized this wonderful climate health dialogue, along with co-organizers, that's the WCRP, World Climate Research Program, My Climate Risk Lighthouse Activity. So we have the IITM hub here. And also from under the World Health Organization and WMO, World Meteorological Organization, we have the Global Heat Health Information Network. We also have the IITM hub. Rup Kumar Kohli is part of it. I'm also part of it. So we hope to work together and hope to take this dialogue further. So as the next speaker, we have Dr. Sandra Barteit. Where is she?
She's hiding.
No,
I was looking for you. Yeah. Dr. Sandra Barteit, she's a research group leader in digital global health at the Heidelberg Institute of Global Health. And her research focuses on leveraging artificial intelligence, data science, and sensor-based technologies to explore the health impacts of climate change on vulnerable populations. And she leads the Carl Zeiss Foundation-funded Pulse AI project. Maybe you would explain us what it is about. And she is actively involved in teaching global health and research methodologies. Yeah, the floor is yours.
Thank you.
Thanks for coming and taking this dialogue forward.
Thank you very much. Good morning, good afternoon. So I will be focusing on how we are leveraging sensor-based technologies to address climate change impacts on health in vulnerable populations. So this will be kind of a cross-cutting presentation on the different projects we have. So essentially, just to give you an overview, this is also the Pulse AI project, but it links many projects, so this is why I'm showing it. So essentially what we are trying to do in these vulnerable communities, particularly currently in Burkina Faso, Kenya and Malaysia, is to generate better data to better understand climate change impacts on human health. So we are doing two things. We are introducing new measurements to better understand health and other measurements to better understand climate or weather exposures. So the first blue box that you see is focusing on how we are doing health data. So first of all, we are introducing sensors. I'm going to speak about the different components in more detail, so I'm just rushing through here a little bit. We have added morbidity questions to these HDSS populations that Rainer just spoke about. So not only focusing on health, but moving forward to also understanding morbidity in populations. And we have also introduced specific climate sensitive health assessments, which I'm going to talk about a little bit in a bit. And for the climate related data, we have implemented weather stations. We are leveraging satellite-based remote sensing data. And we also put sensors in the homes of people, so to understand exposures in the houses of people as well. This generates a challenge in terms of data. So we, as Rainer already mentioned, currently explore how we can use graph databases for that. I will show a little bit how this looks in the next slide. So essentially, these graph databases allow us to combine heterogeneous data. So all these kind of different data that we are generating through sensors, also from the climate data, we are able to link up as vertices and edges and encode the information. As you can see here, we can encode quite a lot of properties, which then allows us also to leverage AI-based methods to understand and maybe discover even new risk clusters based on this data, which then hopefully also can help us to inform better interventions for these specific risk clusters. So essentially, this is the idea of the Pulse AI as well, which is funded by Carl Zeiss Stiftung. We also receive funding through Wellcome Trust for a heat cluster, where we've introduced also these sensor-based cohorts, which is also linked up to the GIN network. And we receive funding for this from the German Research Foundation. So why are we doing this? Because climate change is impacting diseases on a wide scale. So this is an overview, which I recommend you look up, how the pathways from climate impacts is impacting human health. So you can see quite a lot of linkages, looking from a warming planet, from different precipitation patterns that lead to floods, droughts, storms, which are related and impact vector-borne diseases, waterborne, airborne, or diseases of direct contact, foodborne. So you can see there's a quite huge impact of climate change on diseases, which then are climate sensitive diseases. So there's a lot of developments happening, and we are also leveraging these sensors to better understand the impacts on infectious and also chronic diseases. Where are we currently doing that? With this work, we have started in Burkina Faso, in Kenya. So we've been doing this work in these countries for over 6 years now. Those are large or population cohorts, HDSS, just like you have them here in India. So which is great because it provides us a standardized environment for our research, where we essentially can adopt and adapt easily what we have been doing in Africa to also other contexts, like in India, for example. In Burkina Faso, we have cohorts of 120,000 people, in Kenya, 220,000 people. And we are also doing this research in Malaysia, where we have a little bit smaller population, but it's still quite a big population, just to provide you an overview of the different contexts where we are doing this. So looking at coming back at the graph database, so how does this look? So just to give you a little bit of a glimpse on how we connect the different data. So here you can see the brownish dot, which is the individual, which is a member of a household. And we also interlink, for example, relationships between the different individuals. So we also have the socio-demographic data encoded in the graph database. And we can link up also, for example, paludism is malaria. So this is French, paludism from malaria. So we can also link up, for example, infectious diseases like acute episodes of diseases to different individuals. And also chronic diseases. So here you can see this member has this disease episode, which is chronic and is asthma. So and here we have a heart disease, for example, that is linked up as a chronic disease to this individual. So essentially, you can link up a lot of information that way, and we are adding also the sensor-based information that way. So this is basically just a very big zoom into this graph database.
So size mean the number of samples with that condition?
So we have 3 measurements of asthma, for example. Yeah. And this is how, like, we zoom out a little bit just to showcase, so we can zoom into the individual where we have loads and loads of sensor-based measurements through the wearables, for example, but where we also have these cross-sectional data coming from the questionnaires, which we can all link up and which we then can add. For example, here you see a village, and here the individual which lives in this compound, so which is kind of the house. And this is located in this village. So, and essentially we're also adding the weather station data that way. So we're linking up the nearest weather station to the individual compounds. So we always have kind of the nearest weather station data to this individual. So essentially this is how it's encoded, and we can encode a lot of features as part of properties, which are not shown here, but just to give you a little bit of understanding how we are encoding the data in a graph database. For the individual level sensors, we are using consumer grade wearable devices. So here we are using Garmin. Why we are using consumer grade wearables? Because we want to do this on a population health level. So we need devices that are cheap or as cheap as possible, but still have like the highest quality we can get for this money. And this is why we're using Garmin. The Garmin device, the Vivo Smart, essentially it measures a lot of different variables, but the most important to us are the heart rate, the sleep score. It does advanced sleep monitoring, so it also gives us a score for sleep quality. It does the fitness tracking, which is essentially daily activity, so we know how much people move during the day. And the wearable works quite well even in remote areas because it stores 14 days of data. We can easily sync the data via Bluetooth, and the battery life is, well, Garmin says up to 21 days, but typically depending on how much you move, it's around 7 days. So for us, doing this on a population health level, because we use a consumer grade device, we are using a different software, which is called FitRocker, which allows us to synchronize many devices. So when we go to the homes of people in this large population, it allows us to sync the data easily. And we can easily export it as a CSV file, which then is pipelined to the graph database. So basically we have data pipelines that push from FitRocker through CSV directly into the graph database. Also, FitRocker is cool because it gives us already data analysis, so we can already see visually the data of different variables that we measure. So here, for example, you can see the heart rate. It gives us min, average, max. So you can already check while the data is being collected if we have valid data and if the data is complete. So we've also set up kind of these automated messages, but also doctoral students are checking it manually still if the data is coming in complete. And it also gives you like visually some feedback. So you see some people, they move even almost 25,000 steps a day. And we found like one person which has moved like over a week, almost 40 kilometers per day. So it's the first time we have these objective measurements in the population and understand how much they really move and when do they move during the day. Here you have sleep, so you can see the different states. So we have light sleep, awake, and deep sleep episodes, which the wearable can also measure. So we can basically know when the person starts to sleep and when the sleep is ending. And sleep is certainly also a very important variable or indicator for health. We also introduced another sensor. We are doing this now in the population in Malaysia, where we have a sensor that continuously or on a continuous basis measures systolic and diastolic blood pressure, because particularly hypertension is becoming an increasing burden of disease in Malaysia. But I mean, it's a global development, really, if you look at the global burden of disease statistics. So this is a very thin bracelet, which doesn't have any monitor. And it can store data for 30 days. It needs calibration for every 30 days. So basically you have a handcuff which measures the blood pressure and kind of syncs up with the wearable. And you do this every 30 days. So why is this important? Also for India, you can see the maps are very red. I'm looking at cardiovascular diseases, stroke, for example. And we know, for example, that extreme heat and high heat index have adverse impacts on mortality, morbidity, and labor productivity. Also, people with cardiovascular diseases are having increased risk for heat-related health burdens. And yeah, we see this correlation. So very likely, if we look at this in a few years, it will be even redder, particularly looking at projections in terms of temperature and heat exposure for India. So this is important, kind of the ground or the basis for why we do that. And we also see we need much more studies, because it's always the same kind of scenario. So this is observational research of heat impacts on cardiovascular disease, where we see very little research is happening where the most heat impacts are. Also in India, very little research being done. So we certainly need more insights, particularly looking into individual impacts. This is how we do the study in Malaysia. So basically we have them wear the Garmin device and the Axia blood pressure measurement device. And we have like a 4-month study period where we have the people synchronize the data themselves through their smartphones, because many have. And people who want to continue after this phase, they will get the Garmin device as an incentive, so they get to keep it if they agree to send us a little bit more data. And we will compare with another group who doesn't have hypertension, so that we can see differences in the measurements and also correlate with weather data, essentially.
What's the incentive for the first 3 months? How would they do that?
Right?
What's the incentive for the first 3 months?
They get like a little bit of financial reimbursement. Like typical for HDSS, they have kind of a rate. They also give them some towels and stuff. I don't know. They get like a welcome package, and then every month they continue.
Do they have access to their own data?
They can, yeah. So essentially they can on the smartphone. So this will be also cool to look at if it changes their behavior to become more health positive. So maybe we will add a questionnaire to also understand if having access to this data and seeing like how much you move, how your blood pressure is, whether this pushes you more into health positive behavior. Yeah. Also, I just wanted to highlight that wearables are used more and more, but the same story again, so mainly in high income countries. But it's also in India, we found 141 studies who are using wearables already. So it's a new measurement that is adopted more and more, because it gives us novel insights that we didn't have before in understanding health. So just to focus a little bit on the weather stations, we have implemented weather stations in Burkina Faso and Kenya. Those are state-of-the-art weather stations, which we had imported from Germany. and which we have installed throughout the Nuna HDSS area. So you can see the circumference. So we try to cover the study area as good as possible so that we understand actual exposures of weather on human health. And they set up the weather stations themselves because currently Burkina Faso is a bit difficult politically. So we are not allowed to travel there because there's terroristic activities going on. So the team in Burkina Faso set up the weather stations themselves. So this is the pictures they shared, and this is the weather station. So we put a fence around it because there's also always animals and curious children. So yeah, to kind of keep them away of touching the things. And what these weather stations, they're around 10 to 15,000 US dollars per weather station. So setting this up costs around 15,000 US dollars. So it's very expensive. So in an effort to finding better solutions of scaling up weather stations in the study area, we are currently pilot testing 3D printed weather stations in Malaysia. So here you can see this is a commercial 3D printer and the individual pieces that have been printed. So this is working quite well. So this is kind of the wind measuring, but there's also been some development because it's not as easy as you think printing things 3D because it needs the right temperature, needs the right material. So they are quite, so you can see here, this was one of the prototypes where we needed also to redesign kind of the blueprint. So it took a little bit of development phase, but we have the 3D blueprints now fine-tuned. So this is, and you buy some other components like the poles and the cables, and then you basically compile everything. And we even received now a gold award from the Malaysian Technology Expo for this. So it was part of a master students project who then won this prize. So you can see the setup, it runs on a solar panel, and he put also some enforcement on the cable. So this is currently something we're testing in Malaysia, and we are printing currently also the second one. And this 3D printed work is not something that we have done ourselves, but it was initiated by the 3D PAUSE project. So 3D PAUSE stands for 3D printed automatic weather station. And they have provided like the initial blueprints, which we used, and the engineering student then fine-tuned these blueprints. So you can download the different printing sheets from their website. And they provide this open source, so you can also change the design or enhance the design like we have done. They also have a paper where they compared the 3D printed weather station to an actual state-of-the-art weather station. So here you can see a follow-up of 6 months. And here you see some depreciation of the sensor, but overall the values were quite similar to a state-of-the-art weather station, so providing evidence that this works really well. Nevertheless, we are doing the same in Malaysia at the moment, where we compare the 3D printed to a state-of-the-art weather station. Another focal area that we currently look at in terms of climate-sensitive diseases is looking at lung diseases. So we have a study where the objectives are to understand indoor and outdoor environmental exposures on health in people living with COPD, so chronic obstructive lung diseases, and asthma. And we basically compare the health parameters, which we measure with the wearable devices, with continuous indoor and outdoor climate data that we get through the weather stations and also through the sensors that we put in the homes of people. Yeah, so here you can see the spirometer that we are using for that. It produces deep images, which we verify. And the study will involve 64 participants with and 64 without lung disease. And initially we, because it's a larger or the idea is also to do this in a larger population. So we are using these standardized screening questionnaires for COPD and asthma. These are like 10 questions which you ask people. So to quickly understand kind of the burden present and if they may have a lung disease or not. And if it comes out that the likelihood is quite high, then we also do a spirometry measurement. And this is also an app-based device, so it gives us back some lung health measurements directly, which makes it easy for the field workers. So we will follow them up for 1 year, and they will wear the wearable device. We will use the weather station data and the indoor sensor to understand indoor and outdoor exposures. Another work that we are doing currently in Kenya is to use the wearable device, and this is replicating a study in the US where they have successfully developed a Bayesian algorithm to predict malaria infection before the outbreak. And they've done this by just using a wearable device. So we are currently building up a data set so that we can train our own model on the Kenyan data. And so the idea is that you have a lot of measurements on an individual, and you then understand also individual thresholds. So you define or are able to define kind of a healthy range and a range which is not healthy anymore. And the idea is that you then can feed back the information to the wearable device, kind of sending an early warning to the person wearing the wearable device, saying, hey, something seems off, please go see a physician. So this is basically the idea of developing this algorithm. And they were able to predict malaria averagely 5 days before the outbreak, before parasitemia. So which can be very helpful, for example, in scaling up support and understanding where there may be larger outbreaks in the future, also informing NGOs, for example. So here you can see this was like the best case scenario. So the challenge means this was when the malaria infection happened. And visually, you can already see deviations in the heart rate. And here you see the parasitemia. So the parasitemia only happened here. But the algorithm was able to pick up these deviations way before parasitemia. So this is basically what we're making use of in building this algorithm. I have till 1, right? I'm skipping over this. Maybe just quickly. So we are also using this data, rainfall, heat, wearable devices to understand how this translates into nutritional outcomes. So the idea is that more heat and rainfall leads to less crops, and also, as Rainer has shown, more heat strain in farmers, which eventually leads to poor nutritional outcomes in children. So this is kind of the pathway. And just to show you, so we are also giving them GPS devices. So we are able to tell when they were working in the field so that we can kind of correlate that. So this is also something that you're able to do with this data. And maybe closing with that, there's also new approaches on how you can handle the data, which will, we haven't yet started, but this is research by Google, where you can throw in different sources of data into a pre-trained large language model, which then allows you to predict different health tasks. So essentially, they've also put in wearable sensor data, survey data, text, time series data, and then they prompted the LLM. So they trained the LLMs for the different tasks on different data sets. And for example, they looked at the different tasks. So here you have the task of activity recognition. So because oftentimes we don't know what people do for activities, but you can use this large language model, for example, to understand. You throw in some data like the steps, the calories, the heart rate, the sleep. And then you can ask the large language model, what will be my readiness level, or what kind of activity have I been most likely been doing? So predict the activity type among list of activities, giving the following information, which could also be super helpful for us understanding what people are doing, because currently we only have sport activities encoded in the wearables, but we don't really know if people are fetching water, if they're farming, like what kind of activities they can do. And apparently you can throw this data also into this large language model, which has been pre-trained on different data sets. And then you can ask these questions. So, but we will also try to replicate that with our data that comes from Africa. So you can also do this, for example, for sleep quality prediction, where you throw in steps, calories, heart rate, sleep, and then you can ask what will my sleep quality level be. So it can be helpful in also analyzing these different data that we are generating. So I'm closing with that because it's only 10 minutes left. Sorry.
Yeah, if you have a few minutes, if you need a few minutes, you can.
I only have that one. So this is the very last slide I actually have. So kind of looking into how we are translating the expertise that we have. So we have, for example, among many projects we have, but Erasmus Plus project with Thailand, which I mean, we had a discussion before about transdisciplinary approaches and how you need people working together from many different fields solving climate change. It's not something that can be done by one group or one scientific focus, but you need many people. And this is the idea of this master's in transdisciplinary practice, where we are currently setting up modules which then come together as a full master's to essentially have people or students trained in how to work transdisciplinary, specifically to focus on these priority areas, which tie together many interests. So also the Thailand's national priorities. So looking at energy security, food security, and water security, but under the lens of climate change. So this is also where we, for example, develop modules on meteorological data, for example, and have students work on different projects that are climate change and health related. So this is the very last slide I'm having, so I don't have any more for now. So thank you very much.
Thanks a lot, Sandra, for taking us through the world of global health data, how to monitor it, understand it, and make sense of it. I had a question, before anyone asks. So if you or me or someone is associated with a project or a group, it's easier to access this kind of data. So my question is, are there attempts on a global forum to have some of this data, like in open access or, in a global standard, so that it's accessible to, all kind of researchers?
There are discussions.
Yeah.
And also Wellcome Trust, because this work in Malaysia is funded by Wellcome Trust. So it's part of a group called by Wellcome Trust, the Heat Cluster.
Yeah.
And Wellcome Trust also, because a lot of these projects also use different wearables. So just these discussions came up, how we can make the data available. And I've also heard at this Climate Change and Health conference in Harare, a lot of these discussions, because people are very interested in the data, but so far I don't know of any kind of substantiated efforts. It's mostly discussions and kind of people wanting the data, but since the project is still running, we cannot give out the data, and we haven't, we would need to evaluate because we haven't even consented people yet. So we would need to go back and
anonymous.
we would need to figure out kind of how we can make it available. So
at least there are some thoughts about or conversations.
Yeah, there's thoughts and discussions.
Yeah.
But I know actually, by the way, of Garmin, because I just had a conversation with Garmin about like 4 to 6 weeks ago. So they also have this researcher support, and they're planning to make data available so you can plan for a project. and they provide data of all their Garmin devices. So they will have people kind of consented. So they will basically write an email to people who have the Garmin devices that if you want to participate in the study, you will also get access to kind of outcomes of the study. So you can apply, but this is very new. So this will only start beginning of 2025. But Garmin is doing it, and I'm sure others are as well, like Apple. So basically the idea is that you suggest a project to Garmin. They evaluate, they have kind of a committee, and then they decide whether they want kind of, I mean, that was what he told me.
They also benefit from that.
Yeah, I mean, but basically it's their data, but they provide this access. And in the beginning, he told me they want to have like large institutes and larger scale studies, but Garmin is doing that. And I'm sure others are doing that as well, but maybe you will not have access to other kind of, I mean, it depends, because I also don't know how they make the data available, like what, the data will look, whether they aggregate it or, but I'm certainly applying for such a project because, but this is happening. But from us, there's always the difficulty since we are funded through Wellcome Trust and we didn't consent people, so it's always a bit difficult. Yeah.
Just one thing, Sandra, thanks for very nice presentations. What is the cost of this?
Use the microphone so that.
So I was just wondering, what is the cost of those wearable devices?
The Garmin ones, they cost around $90 US.
Mm-hmm.
So it's as cheap as it can get. And Garmin has very good quality, like, because we also needed a device that has the European standards and which we know is like of high quality. So this was kind of the best balance we could find. Yeah.
Yeah, thank you very much for that presentation. We have a similar requirement in the Wellcome Trust project that I mentioned this morning in getting information from individuals in 2 cities. There's one related challenge that we had to go through, that is getting the ethical clearance from the concerned authorities and also compliance with the privacy protection laws. So what is your experience in handling this type of challenge?
And privacy in terms of individuals.
Local governments or national government, they may have their own privacy protection laws in accessing individual information.
Yeah, since we are working together with these HDSS, health and demographic surveillance systems, they're attached, for example, in Burkina Faso to the Ministry of Health. So they are kind of an independent agency, independent research agency. So they have their own ethical review board. So we've basically presented them the work, and there was no concerns in the way we are using the data in terms of individual privacy. But again, if we wanted to make the data accessible, that would be a different story. But we are using the data, in the way we intend for understanding individual impacts of climate change. So there were no privacy concerns. We have some privacy concerns from study participants in Malaysia. So there's cultural differences because we didn't have that before in Burkina Faso. In Kenya, people were very happy to be part of the study and to have this wearable device because it also provided them with a watch. So we received some positive feedback where people were very happy and even told us they're wearing the wearable to go to the market. So as like kind of a fashionable, jewelry-ish thing. But in Malaysia, the situation was a bit difficult. We had a bit more problems onboarding study participants because of privacy concerns, mainly from the Chinese population. Yeah.
Yeah.
Thank you, Dr. Sandra. That is a very interesting presentation, especially the slide where you showed that the zoomed in picture of how an individual with a particular disease is likely to affect the family members and community at large.
I was just interested to know your thought regarding the sustainability of these kind of devices, and actually if we were to follow this up as a cohort study or any of those things, is this a sustainable way in collecting information, and what do you think the compliance would be of people in the long term?
Yeah, very good question. I mean, when we introduced these devices in Burkina Faso, because people don't have them, so we provided them the devices. So it was new to them, so nobody's used of wearing those. So it was kind of a new thing on their arm. Some had some itching in the beginning, but we have been doing this in Burkina Faso for 2 years, so adherence is quite high. And we also have now in Kenya, where we stopped this malaria study I presented. So we stopped the data collection because we finished our time, where we have now to send field workers to get the devices back because people don't want to give them back. So, so we have to send people there to strategically communicate with them so they don't feel offended. But we were thinking also doing the same thing as we do in Malaysia, where we have the people, or we give them the wearable device, and they then agree to continue to provide us the data for some time at least, so that, you know, we get some benefit and they get to keep the wearable device. And as Roxy said before, giving them access to this data may also kind of nudge them into more like a health positive behavior, because they see how much they move, how their heart rate is, how much they sleep. So maybe they thought before, oh my God, I'm sleeping like 8 hours, but then the wearable tells them, no, you've been sleeping only 4 hours. So where they maybe, you know, through the wearable device have a more positive kind of health pathway along in the future. In terms of sustainability, I mean, in Burkina Faso, we've been using it for over 2 years, and Burkina Faso is kind of extreme because it's very hot. So we have temperatures over 40 degrees Celsius for weeks. It's very dusty. It's very dry, but at the same time, when you have the rainy season, there's also quite a lot of precipitation around. So in terms of the devices, the Garmin devices have very good quality, so we find few of them damaged. And sometimes it's because of individual behavior, it's not because of kind of device malfunctioning. So if you have an environment like Malaysia where people can push the data themselves through the smartphones, because in Burkina Faso, most people don't have smartphones. So we have to send field workers. But if you implement this in the HDSS in a sustainable way, we are working on it, on how to making it more cost efficient in environments where people cannot share the data themselves. But maybe here in India, you also have more people having their own smartphones, so they can push the data themselves. So maybe you can have like a similar setup where you say, okay, they get to keep the device, and then they basically, because the data is being pushed automatically through Bluetooth, so they just have to open the app maybe every other week, and then the data gets synced to the server. So this is a very easy process. So in an environment where there's a smartphone available and electricity is affordable, I think it's very sustainable. For other environments like Burkina Faso, we are still figuring it out, like how to make it more cost efficient.
Sandra, so have this is this data from the Garmin devices comparable with the other devices like the Apple?
Also, yeah. So is the data from all these devices comparable, like from the Garmin ones, comparable with the Apple ones or other Android devices?
Sure. Because essentially they're using the same technology. So you have an actigraph, you have a light sensor. So the technology behind is the same. I mean, Apple provides further measurements. So they have an electrocardiograph integrated, which you can use. So the technology that Apple provides is more sophisticated in that they offer more like FDA approved measurements than Garmin does. And I mean, Apple provides like this whole, you know, display and stuff. So Garmin is much more simple because you have kind of a digital display, which shows you kind of in a small way the time, but also the blood pressure measurement. I mean, it is able to show the necessary information, but it's not like in a fancy way like Apple does. So in terms of measurements, yes, the ones we're taking are essentially based on the same technology. It's just that we do not have these additional measurements and kind of the fancy way that Apple is able to display, because they provide more sophisticated technology in terms of how they can display things on the monitor.
You can take one more question. Yeah. Okay. Quick question. Two quick questions.
Hello. Yes, ma'am. The study is very interesting. I want to ask one question. Just doubt that if like how wearable device is sufficient to measure malaria disease, and like that particular person can have some other infection. So
right.
How it is sufficient to correctly measure it without blood test or like that?
Yeah. So currently the data set that we are collecting is annotated with malaria outcomes. So we are training the algorithm to detect kind of patterns based on the malaria data that we are providing. But certainly heart rate can be like all over the place because of other infections. That is very true. This is something where we do continue our work to collect data from other specific diseases, so that maybe in a few years we're able to say, okay, this is dengue, this is malaria. Maybe we're able to differentiate. I mean, I don't know yet. But in the end, it's about early warning system. So it's better to, you know, be more kind of informative towards the user to avoid kind of let's say, bad development in terms of the disease, so that the person is able to see a physician early on before even the outbreak of the disease, whether it's malaria or dengue, for example. So in that case, it's better to over-communicate. So in that sense, if we see a deviation, it's always a positive, like in my point of view, communication to let the person know that something is off, to go see a physician, and we can say, okay, likely it's malaria, because we are training the algorithm on malaria at the moment. But maybe like also the movements, like for example, if you have a wearable device, the wearable device is able to differentiate between different activities. So whether you're on a bike, whether you're swimming, whether you're running, whether you're playing tennis, whether you're playing golf, some of these activities are quite similar, like maybe dengue and malaria. But it's still able to differentiate. So I guess the more, my estimate would be the more data we have, and the likelihood of us being able to differentiate through the wearable data between diseases increases. But at the moment, we train it only in malaria data, and we're intending on collecting more data. So maybe we can look here in India into collecting data on dengue. Because it's an increasing threat. So yeah, hopefully this can inform us in the future to be able to tell the person this is dengue, this is malaria. So.
One last question.
It was really a nice presentation. I have a question about the selection of cohort you have done. So what is the strategy you have followed, like so that like a representative cohort is selected in terms of age, in terms of gender?
For which study, or like
I mean,
any
like,
study?
yeah, for your study.
Currently, we include study participant above the age of 18 because we found that it doesn't work well in these families, in Burkina Faso and Kenya specifically, because we found that mothers took the wearable device, that the children weren't wearing it anymore for some reason. But this was happening. And we found out by accident. So currently we include people above the age of 18. And for the cardiovascular study, we also for asthma and COPD, we look at study participants above the age of 40, because this is typically when you, I mean, not for asthma, but for COPD, where you have a higher likelihood of having developed COPD. So we are focusing the cohorts on the different diseases that we're looking at. But currently, like a general thing is only people above the age of 18, if this was your question.
Okay, additionally, like, I mean, like, most of the time people spend different, go in
Right.
different environments. So outdoor and indoor time, have you just looked at that, how much time people individually spending in outdoor and how much time it is spent in indoor?
Yeah.
So based on that, like your results are affecting maybe.
Yeah. We're not, I mean, we know how much people move. But it's true, we don't have yet this kind of assignment of indoor or outdoor. I mean, we have been using in this other study, I've shown shortly GPS devices, but GPS devices are difficult because the battery only lasts for like 24 hours. So we cannot give people GPS devices because it only, I mean, we can give it, but it's not for a longitudinal follow-up. It's only for up to 24 hours. So we would need to think in more clever ways to understand if people were indoors or outdoors. Currently, we don't follow up on that, really. We just kind of look at it on an average basis in terms of exposure variables that we measure. Yeah, that's true.
Thanks a lot, Sandra. That was beautiful, and we hope to keep this conversation alive. So both the talks are available as video in YouTube. The links will be shared as well, and we are happy to host you both. Yeah, and very lot of thanks to Dr. Revdi Falkesh. He has been working with the Heidelberg University as well, and she has been in charge of the climate health section or directorate in the UK. Yeah, and she has been working on many of these kind of research studies for Africa, Asia as well. Yeah, thanks for bringing us together, and thanks to you all. Thank you very much.